Hi everyone. Let's go ahead and start with section 3 of chapter 19, and this is looking at heart anatomy. So there's a lot more in the book that's covered than what we'll cover here in lecture, and there's going to be some structures that you'll see on APR that we're not going to cover as well. So as always, if you ever have a question about anything in APR, just let me know, just send me an email. So let's go ahead and get started, and what we're going to do is take a look at the superficial features of the outside, and then we're going to kind of cut inside and take a look at some special features in there as well. And then we're going to go in and take a look microscopically at the actual cardiac muscle tissue as well. So let's start by superficial features. So once you take that heart and just look at it without cutting into it, looking at the anterior view here, if you notice, some of the prominent features are going to be the right atrium, specifically this right auricle. This right auricle is more like a flap. I call them flaps because if you've ever seen a heart outside of the body, or if you've done a dissection before of the sheep heart or anything like that, then they have these little things that look like chicken wings, and those are actual auricles. And auricles are going to be expansions of the atria. So that's what you see right there, more the prominent feature. And then, of course, another one is going to be that right ventricle. You have lots of these little coronary vesicles, or vessels, I guess I should say, not vesicles, right there that we'll get into in another section. But other things that you can see, you see a little bit of the left side over here. That big pulmonary trunk and that big giant aorta is going to be very obvious as well. And then you can also see the pulmonary artery, more prominently that left pulmonary artery, because the right is kind of underneath the other vessels. All right, so let's flip it on back and take a look at the posterior view. So the prominent features, there's that left atrium, and then there's that left ventricle. Those are going to be the prominent features. This is where you see a lot of those great vessels that we weren't able to see in earlier sections. We were talking about blood flow in the great vessels. This is where they are right here, kind of hidden behind. You see the pulmonary arteries a lot better and the pulmonary veins a lot better, as well as the vena cava. Don't worry about the sulci, or sulcus is of course singular, sulci are plural. This is just going to be kind of these grooves or indentions that the coronary arteries are going to sit inside, but don't worry about those. We'll talk about the coronary sinus later on. All right, so now we're going to go in and kind of cut into the heart, and we're going to look at it horizontally first, because we want to take a look at compare the left side and the right side, specifically of the ventricles. And why we're going to take a look at specifically the ventricle and the walls of the ventricles is because, remember, they are the pumping chambers. And because they're pumping chambers, and because they are pumping to different parts of the body, that's why we need to talk about how one is going to be thicker than the other. Let's go and look at this view as well. Look at that left side of the heart. It is super thick if you compare it to the right side of the heart. And if you look at it on this horizontal view, you can see it a lot better as well. So if you think about where the blood is going from each of the ventricles, with the right ventricle, remember we wrote out the blood flow, and the right ventricle is basically sending it to the lungs, which the lungs are right next door to the heart, right? So you don't have to generate too much pressure to generate enough force to pump it over right next door. So, but if you think about the left side and where it's pumping to, this sends it to all of the systemic cells. So it has to pump it hard enough, or with greater force, with enough force to get it to your fingers, to get it to your toes, all of the different places, all of the different systemic cells. So that's why, we'll take a look at, this is going to be your myocardium. This is where that cardiac muscle tissue is going to be. So more cardiac muscle tissue means that you're going to be able to generate enough tension to generate a high enough pressure in order to force the blood through that systemic circulation. So it's a really interesting kind of fact about the heart, how it's going to be a lot thicker on that left side. All right, now let's go ahead and we are going to take a look at a piece of the wall, the heart wall. And we're going to go in and look at the 3 layers of the heart wall, which you see right here. So let's go in and take a look at them. We're going to start on the outer layer of the heart and move in. We've introduced this before. You remember that pericardium? Remember the pericardium is just the visceral pericardium. It is going to be that simple squamous epithelium, and it's going to be the underlying areolar connective tissue. And as you can see, there's going to be some nice adipose tissue in there as well. Now if we take a look at the largest layer, the thickest layer of all 3 is going to be this myocardium. And if you think about it, it makes sense. I mean, the whole function of this heart is to be able to contract and pump blood to where it needs to go. So yeah, you want to have more myocardium. Remember that myocardium, this is going to be mainly cardiac, it's going to be cardiac muscle tissue. And again, we'll get into it later on and take a look at the cardiac muscle tissue. All right, and then this is going to be that inner lining of the heart. So if we went back to this, we're looking at this kind of inner layer right in here that's going to lie on top of all of that. So it covers the internal surface, but it also covers the external surface of the valves, and it's going to be continuous with the blood vessels. All right, so now let's go ahead and take a look at a coronal or frontal cut of the heart, section of the heart. So remember you have 4 chambers. You have the atria, the 2 atria, and you have the 2 ventricles, and they need to be separated. So there is going to be this separation that you can see. Here is that interventricular septum that's going to separate the right and the left side here. You can't see the one that's separating the atria right here. You can see it a little bit. I mean, this is right in here is a little bit, but it's not going to be this nice separation in here. If we went in and kind of dissected a little bit more, you would see a nice interatrial septum. But there is going to be a separation between the 2 atria. All right, let's go in and kind of dive into the chambers and look at some special features in there as well. You have pectinate muscles. It's kind of that little ridgy surface that's in the atria. Some parts don't have the pectinate muscles, as you can see right here. Look at this. This little thing is going to be a fossa ovalis. And the fossa ovalis is going to be a really thin tissue that's going to be found between the right and the left atrium. And what it is, it's going to be this tissue that forms at birth to close up something called the foramen ovale. The foramen ovale is going to be a fetal structure that allows blood to flow from the right to the left atrium to bypass the lungs. And we'll get into that when we get into fetal development. But it will close off at birth and it will develop this thin tissue, and that tissue is the fossa ovalis. There's that entrance to the coronary sinus I already talked about when we talked about blood flow. And of course you have the entrance to the inferior and superior vena cava. And then you have the exit. So there's always going to be entrances to the chambers. If you think about it, it's a chamber. And then there's going to be an exit as well. But there's going to be a door that's going to close off the atria from the ventricle that can open and shut, and that's going to be, of course, your tricuspid valve. Let's take a look down here into the right ventricle. You have something called the trabeculae carneae. It's an awkward thing to say, isn't it? That's going to be these kind of more prominent ridges that you can kind of see in the ventricles. All of this stuff you can see as well over here on the left side of the heart. You also have these things called papillary muscles. That's what this is, this one, and this one. And then you also have 2 on the other side. And look, they have something attached to them. That's going to be the chordae tendineae, or you can also say chordae tendineae. Either one. I've heard them a couple of ways. So these are literally your heart strings, but of course they're not made of thread. They're made of this stronger fibrous tissue. We'll talk about their function here in a little bit. As you can see, they are going to be attached to those 2 AV valves. and the two chambers there. All right, so as far as the exit, superior exit is through that pulmonary semilunar valve into that pulmonary trunk. Let's move over to the other side, the left atrium. Again, you can't really see the pectinate muscles over here, but there is some in that auricle. The entrance you have is going to be the pulmonary veins. You have the two over here from the left, and then the right you can't see. Exit is going to be through that mitral valve or bicuspid valve and into that left ventricle. Let's take a look at the left ventricle. Again, you still have some of those ridges that are going to be those muscular kind of prominent ridges that are going to be found in there. Two papillary muscles. And again, you have more of those strings, those cords. And the exit, you can't see the exit very well, but it has to go through that aortic valve, and then it's back behind that pulmonary trunk from there. All right, let's go ahead and take a look at these valves a little bit more. And I know we've already talked about them, but let's talk about, we'll talk about their function, how they kind of work as well. So their main function, all of them, is going to make sure that blood through the heart flows in a one-way direction. It's really important for this to happen in the heart. So again, we already know the valves. We have the tricuspid, we have the bicuspid, we have the pulmonary semilunar, and then we have the aortic semilunar valve. These are going to be made of an endothelium lined fibrous connective tissue, and they are going to be kind of these little flaps or cusps. This one's called tricuspid because it has 3 of these cusps. And as you can see, at the bottom of the cusps is going to be the cords, the chordae, the chordae tendineae. It's a tongue twister, isn't it? And they are all going, each one of them are going to be connected to the papillary muscles right there. Same on the side over here. This one is called a bicuspid, so it only has 2 cusps, and the cords are going to be connected to 2 papillary muscles. So because they're made up of kind of a connective tissue, they need to be very flexible and very elastic because they're constantly kind of closing and opening and closing and opening. As we get older, this elasticity and flexibility decreases with age, and we'll talk about how this can cause a lot of issues with, with leaky valves and stenosis and things like that. This is kind of an interesting picture here as well. This is going to be kind of that coronal view if we went in, I guess, and kind of cut it right in here somewhere and looked at it. Sorry, that wasn't coronal. The transverse view. This is the coronal view. Remember where you cut. You have a front and a back portion. This is the transverse view. So it's kind of like we cut it right here and we're looking down that way. So it's kind of an interesting picture. Let's specifically talk about these 2 valves right here, these 2 AV valves, the tricuspid and the bicuspid. What they do is they make sure that blood does not flow back into the atria. So blood is going to flow, whenever it's open, blood is going to flow in from the atria to the ventricles. Now when it's time to move that blood from the ventricles to where they need to go next, these are going to shut. And the reason why they're shutting is because we want it to go this way. We do not want blood to go this way. We don't want it to kind of regurgitate back into the chamber. I mean, that reduces our blood flow out of the heart. It reduces something called cardiac output. So these are going to make sure they're going to shut whenever the blood is moving from the ventricle into the next great vesicle. I keep saying vesicle. The next great vessel. All right. So let's take a look at the semilunar valves. The semilunar valves are going to prevent backflow back into the ventricles. This is what we do not want to happen. Remember, we want it to happen this way. This is what we want. This is not what we want. So they prevent that from happening. Look, they do not have any kind of the cords, and they're not attached to any papillary muscles as well. So they are going to kind of open and shut a little bit differently. I mean, all of the valves are going to kind of work on this whole pressure system or pressure gradient to open and shut. And we'll look at that once we get into the cardiac cycle. but the things that kind of keep them shut are going to be a little bit different. So let's take a look at the mechanism of action. All right, this is when the AV valves are open. Look at that, blood is flowing, it's open, it's going from the atrium to the ventricle, so blood can flow that way. Let's take a look and see what happens when we want this ventricle to move up into the great vessel that is next, the pulmonary trunk or the aorta. So what happens is the pressure is going to build up in here, and it's basically going to close these valves. And then, of course, blood is going to be forced into, if this was the right ventricle, it's going to be forced into the pulmonary trunk. And that really is what's going to help go in and shut the valves closed. It's going to be this kind of pressure difference. But we need to make sure that these stay closed, because the force is going to be so great, or the pressure is going to be so great, that if they didn't have these cords, they would actually flap back into the atria, kind of like if you went in and cut the lines of a parachute, it would flap back up into the air, which is not good. So the cords are going to be there to help secure and to help keep those AV valves closed. So what happens is the papillary muscles are going to contract, and when they contract, they are going to kind of pull on the cords, and that is going to pull on these in order to keep them shut. So very, very important there. Let's take a look and see how the semilunar valves work. So here it is. Again, you have this pressure difference that is going to eventually cause the semilunar valves to open. So that is going to force that blood is going to force the valves open so it can move through because of the pressure change. And then what happens is that the pressure is going to drop. So the pressure in the ventricles is going to become less than the pressure in the atrial trunk. And because of that pressure, blood is going to want to start to flow back because that pressure difference. Blood is going to want to flow back because blood moves on a pressure gradient, meaning that it goes from a high to low pressure. And if this starts to drop, then it's going to want to flow all the way back. But we don't want that happening, right? So that's why these are going to shut. So they kind of act like cups. And as soon as the blood starts to come back, they are going to kind of catch them in their little cusps right there. So that's what they kind of look like, is a bit of a cup-like structure right there. So that makes sure that they don't go back to where they should not be. So let's take a look at how doctors can go in and listen to the heart, specifically going in and listening to those heart valves and using it for clinically important or clinical diagnosis, I guess I should say. So there's whenever your valves close, whenever this happens, whenever the semilunar valves close, and whenever these AV valves close, they are actually going to make a sound. And that is where those heart sounds come from. Whenever you put the stethoscope on the heart and listen, you hear this lub-dub, lub-dub. And there's a total of 4 heart sounds. 2 of them you can actually hear very well, and they are going to be the 2 familiar sounds, the lub-dub. You have an S1, and that's going to be when the AV valves close. So your tricuspid and your bicuspid. So if you kind of take a look and see where they're located, let's go back. They're a little bit lower, you see, than the semilunar valves. So that's why when the doctor is going in and checking, he's actually checking a little bit the lower parts that he's checking. He's actually going in and checking the AV valves. So they are going to give off the first sound, that lub sound, whenever the AV valves close. The dub sound is going to come from whenever, just very quickly after that, it's going to come from the semilunar valves that are shutting. So whenever this is happening right here. And they're going to be more a little bit more superior. So that's whenever he puts the stethoscope a little bit higher up on the chest. There are a couple of minor heart sounds, S3 and S4, but these are the main ones that you need to know. So doctors can go in and diagnose heart murmurs and other information about the heart and the valves, but one of the most common things that they can go in and hear is going to be a heart murmur, which is an abnormal sound. And really what it is, what the doctor is hearing is this turbulence of the blood trying to pass through the heart or the valves. There's a couple of reasons why the valves aren't working. Maybe they're not closing all the way because they're no longer elastic, so they're not closing fully, or maybe they're stenotic, so valvular stenosis is going to be where they kind of stiffen, and that happens with age sometimes. And so they're not able to close all the way either. When they're not able to close all the way, you can actually, the blood is going to kind of regurgitate back into another chamber. So, for instance, if there was a problem with, I think a common one is that mitral valve. If there's a problem with that mitral valve, which is not good because this is the left side of the heart and this blood needs to get to all of the cells of the body. So if this is not closing properly, then that means that some of the blood is actually going back into that atria. And that is, of course, going to reduce the amount of blood that gets to the rest of the body. So there are specific locations that the doctor goes in and puts the stethoscope on, and you don't have to worry about the exact locations here in lecture. You will identify them in the lab. You'll be looking at it in the lab, but not here specifically in lecture. So the next video that you guys are going to be taking a look at, because I'm going to break this big section up into a couple of videos. We're going to be taking a look at the fibrous skeleton of the heart, and then we're going to be taking a look at kind of diving in and looking at the kind of microscopically at the heart muscles. So until next time.